Assalamu alaikum. Welcome everyone on board. We will continue from where we stopped yesterday. Uh, actually, we are trying to learn anesthesia with approach from MCQs. Yesterday we had first session, and I will just quickly revise what I discussed yesterday. That learning through MCQs is very effective if you understand that when you are practicing, these are all practice MCQs. Even if you have previous MCQs pools, even then your approach should be in a way that you are just practicing the topics or practicing the points what they are asking. Okay. So not only that you should find the answer, of course, but you should try to understand that what points or what knowledge, like raindrops, you can get from that specific MCQ. Okay, so like if you just have a look on this top in this MCQ, the main point is on venous thromboembolism. So since Wajiha, you are here, I will just ask a question. What do you think? What are the risk factors for venous thromboembolism? Can you speak out, Wajiha?
Sir, risk factors for venous thromboembolism.
Yes.
Sir, these
G.
are bedridden patients,
Okay.
obesity, high risk surgery, and previous history of any DVT or hypercoagulability, coagulopathy,
Okay.
disorder of congenital disorder related to factors, coagulation factors, and
What about carcinoma?
cancer surgery. Yes, sir. And
Not cancer surgery, cancer patient. And immobilization because of a number of things. Okay. So, is what is relationship between venous thromboembolism and regional anesthesia? Is there any advantage of regional anesthesia?
sir, regional anesthesia has an advantage over venous. It decreases the chances of venous thromboembolism
How?
as
How? How? How?
it the
Can I?
there is sympathetic blockage, so there will be venous dilatation and blood flow. Uh, this is the
Not
reason
not venous
I guess.
dilatation. Stress is leading to sympathetic stimulation and vasoconstriction and maybe uh, stasis. Okay. So stress is related to, so actually when we do sympatholysis, we are blocking that pathway. Isn't this like that? Okay. So let's have a look. Just a second, please. Okay, so if you just concentrate here, uh, one of the risk factor, another risk factor is OCPs. Okay, pregnancy is a hypercoagulable state. This is also leading to increased risk of thromboembolism. So here, what is the situation that this lady is HLS tendon repair. So HLS tendon repair means the patient has some condition, whether it is traumatic or something like that. Maybe the patient has some immobility. Okay, and general anesthesia itself is a risk factor for thromboembolism, especially if the surgery is prolonged. So prolonged surgery is another risk factor for thromboembolism. So this patient was also on OCPs. Okay. So, and she will need a below knee plaster cast. So cast, another risk factor for immobilization and stasis of blood. So these are all. So you can say that there are number of risk factors in this patient. So when we think about of thromboprophylaxis, there are so many points which you should be thinking that there will be some things which are related to like uh, without any pharmacological intervention. So that will be early mobilization, good fluid management, okay, good analgesia, avoidance of sympathetic stimulation. These all will be related to it. There are then certain physical things like this elastic stockings and a pneumatic compression device, which is compressing the legs, like you can say they are working like that because our legs are our peripheral heart, so they are pumping the blood back. So that is another thing which we is like it's leading to sort of thromboprophylaxis. So here yeah, they are the answer will be on the basis that how much are the risk factors and how much thromboprophylaxis is needed, because all of them are treatment advice on mobilization and fluid intake. This is also graduated compression stockings and immunity compression device on day of surgery. This is also a factor which is helping graduated compression stockings post discharge for 7 days. Single dose low molecular weight heparin on the day of surgery. Heparin will be leading extended course of low molecular weight heparin post discharge. Okay, so we have to choose which is the most appropriate answer. So what are your votes? Because this will not be answer, because that will not be enough, because there are relatively more risk factor on this patient. The graduated compression device will not also be, in my opinion, maybe I'm not sure what will be the answer, but I think these one and A and B is not answer. So, okay, Sayyid Muhammad Ali Shah, what do you think? What should be the answer?
They will so,
Yes. Okay, let's see.
तो लॉन्ग हाँ चलो देख लेते हैं
Extended course of low molecular weight heparin post discharge. Actually, I will tell you something that a number of time such questions are on the basis of some guidelines. Okay, so I will also open. I think this one I have this one in our Google Drive link. So let me, because this is a relatively old book. Okay, so they have put the guidelines of 2010. So I will show you the guidelines for 2018. I think I have it here, right here. Just a second, please. So the learning objectives for this MCQ can be, because thromboprophylaxis and the risk of thromboembolism is a very big topic. Okay, but basically, if you like concentrate on how, so one thing is that how the thrombus is formed. Okay, and what is the mechanism of thrombogenesis. This is one point, and the other point is I think just a second, this is 2018, yes. Okay, so this question is based on 2010, but this is the document which is there for relatively, I'm not sure whether there is some even further guideline is there. So it is a long document. Uh, so let's see. Just a second, please. Okay, here we go. So like as I told you that what is the mechanism of thrombus formation? So you should be knowing what is the extrinsic pathway, the intrinsic pathway, and the latest guideline. Sorry, the explanation is. Can anyone tell what is the new guideline or new model for coagulation? or thrombus formation? Yes,
Sir,
Ali.
are you talking about Virchois triad and causes of
No, no.
thrombus? Mhm.
Cell-based model. We are going even further. Okay, so that is cell-based model of coagulation. That is initiation, amplification, and propagation. We are going even further in depth. So if you want to revise, should know how coagulation occurs. Okay, how thrombus formation occurs. Then you can say that what will be the condition in which there will be more thrombus formation, and what is the system which which breaks the thrombus? What is that system?
The antifibrinolytic system.
Not antifibrinolytic system, fibrinolytic system.
Fibrinolytic system, yes.
Antifibrinolytic which we give. That is what is the name of that medication?
Transamine से tranexamic acid.
Tranexamic acid. So, and now again, you can even expand, because if you are reading this MCQ, if you want to understand these all things, because they have asked you this question, these are all right and left things which you should understand. So the mechanism of action of tranexamic acid, do you know? As you said, antifibrinolytic. So what will be the mechanism of action for tranexamic acid?
Yes, sir. Basically, it is a antifibrinolytic and blocks the plasmin to convert into plasminogen. That is why fibrin strands remain long time than usual.
Plasminogen to plasmin, not plasmin to
Yes,
plasminogen.
sorry, plasminogen to plasmin, and the
Okay.
preformed clots remain for longer time.
Yes, for the small fibrin clots, they are not breakdowns. You are blocking the factory which is breaking down the fibrin clot. So this is the mechanism. So coming back here, this question maybe they have made on the basis of nice guidelines. So they are saying that patient factors and clinical judgment, surgical procedure with a total anesthetic or surgical time more than 90 minutes, or 60 minutes if the surgery involves a pelvis or lower limb. So this is one point. Okay. So this is one risk factor which is there. Active acute surgical admission with inflammatory or intra-abdominal condition. So this may be an inflammatory condition. Okay. Expected significant reduction in mobility. This will be there. Okay. Then there will be certain things like active cancer or cancer treatment, age over 60, critical care admission, dehydration, known thrombophilia. So now all these things you need to revise. What is thrombophilia? Obesity. What is the classification of obesity? Okay. You know, I tell you something. Initially, when you are preparing for any exam, or even if you are learning, even one MCQ can take a lot of time. But the learning which you will be getting will be long lasting. Okay. So this is the purpose. So you see varicose veins with phlebitis, use of estrogen containing contraceptives, use of hormone replacement therapy, personal history of or first degree relative with a history of VTE, one or more significant medical comorbidities like heart disease, metabolic endocrine or respiratory pathologies, acute infectious disease, inflammatory conditions. So all these are risk factors. Okay. So, pharmacological prophylaxis should be continued for 5 to 7 days if significant reduced mobility is expected. This patient has three risk factors, and extended pharmacological prophylaxis is indicated. In addition, she will have a lower limb plaster cast where NICE recommends that prophylaxis should be continued until the cast is removed after discussion with the patient and evaluation of risk and benefits. Exact duration will vary between centers. So, what is the learning objective for this MCQ? That how many risk factors for venous thromboembolism patient has, and accordingly you will decide what level of care will be needed. So if you come back, what they are asking, what is the best form for venous thromboembolism prophylaxis? All of them are helping. Okay. So maybe they will try to mobilize the patient in a way that patient is able to move the other part. Of course, this part will be immobilized. But if the patient is totally immobilized, the risk will be increasing. So this is one thing. Good fluid management will be required. Patient should not remain dehydrated for a long time. Okay. Then graduated compression stockings and pneumatic compression device on day of surgery. During the surgery, this may be placed. Okay. If the surgery is too much prolonged. And then graduated compression stockings may also be needed. And single dose low molecular weight heparin on day of surgery if there is no if we have placed epidural, so accordingly 1 to 2 hours after uh, the placement of epidural catheter will be we can give heparin. Okay. Then next step will be that what are different types of heparin. Okay. What are alternatives of heparin? Like the next question is also almost the same topic. So let's see. 65-year-old woman is scheduled for an extended abdominal hysterectomy. Okay. She is not on any anticoagulants, but 2 years ago she developed a blood clot following a total hip replacement. Okay. So you can see that there is history. So just now we had a look. At that time, her treatment injections caused a wound hematoma, and she was put on blood thinning infusions for several days. At the end of the treatment, she remembered having investigation for low platelets in her blood. So they are giving a scenario of something which decrease will lead to thrombocytopenia. So a condition which is related to this sensitization, this topic is called as heparin-induced thrombocytopenia, HIT. Okay. So there are certain medications which you cannot give if the patient has HIT. So you cannot give Claxane, you cannot give heparin. Okay. So there will be some alternatives that are fundoparinox or lapiridine. So these are two medication which they are using. Okay. So or let's see what they have. So for immediate perioperative prophylaxis, this time the best treatment would be a heparin infusion. It will not be there. Treatment with the low molecular weight heparin, no. Fundoparinox can be given. Low dose aspirin orally throughout the perioperative period. Aspirin is not uh, uh, antiplatelet. It is not anticoagulant. It is antiplatelet. And danapride infusion. Let's see the answer. Actually, this was the answer for danapride. So what is danapride? Now here we can revise this topic in a better way. They have given a very good explanation. Venous thromboembolism is of major clinical significance given that up to a quarter of patients with risk factors may be affected subclinically or clinically. Uh, okay, so mechanical methods, embolism stockings or thromboembolic stockings, TEDs, okay, are graded to provide increased compression from distal to proximal. They are effective at promoting venous return, increasing the speed of blood flow, but not suitable for all patients, such as those with arteriopathy. The arteriopathy means there is some insufficiency. So if you compress it, it can create some problem. Intermittent calf and thigh compression devices produce pressure of approximately 40 millimeter mercury 10 times per minute to emulate the limb muscle pump. Okay, so they are mimicking the limb muscle pump, which is we are using by our contractions when we are mobilized, when we are moving. Okay, so next is heparins. So unfractionated heparin is a naturally occurring antithrombin binder. This inhibits factor 10A and thrombin, and in high doses also has antiplatelet function. So this is the mechanism. It is working through antithrombin 3. Okay. So low molecular heparin is more effective than subcutaneous heparin, has a low risk of bleeding and less antiplatelet effects. So that's why we frequently use, and actually because it's a relatively long acting, so we can use it. It's easily used as compared to heparin infusion and less frequent doses. Okay, so but is less controllable than a heparin infusion and accumulates in renal failure. So that's why they decrease it. So another question just for the learning, that how can you monitor the uh, heparin in infusion, sorry, heparin effect,
Sir, heparin effect for unfractionated heparin, APTT is the good marker,
or there is a bedside
and
test. Bedside test, what is the name of bedside test?
bleeding time.
No, bleeding
So
time is
that is
with
the first
reference to platelets.
the
Platelets. Actually, that's one which we do in cardiac. We give heparin and we
activated clotting time. Activated clotting
very
time.
good. So ACT, activated clotting time. Another option which you should in your list, that is, what is the third test you can that can help? Thromboelastography or
Uh,
autumn. Very good, Ms. Eba. So that's how.
and
And when you are preparing, again, I tell you something. This is one of the topic which always haunted me. They will tell the names, and I never remember the names of fundoparanix and danaproid and liporidin, and there are so complicated names. So, but this topic is very important. And when you are preparing this topic, prepare for from all the aspects, because if you understand, that will help you. So, thromboelastography or TEG will be also monitoring. But for low molecular weight heparin, what test we need to do is factor
yes,
10A assay. Okay.
affected
So,
is the test for
and
low
actually,
molecular weight
we cannot
heparin.
reliably monitor. For warfarin, this is a PT or INR. Okay.
Yes, sir. Perfect.
So,
And
what is
sir,
the reversal of warfarin?
FFPs, potassium, and for acute, there is PCCs, prothrombin complex concentrates.
Very good. Prothrombin complex concentrate. And there are three factors and four factors. So, what are those factors? 27910 or 279, I think. You can reconfirm.
Yes, sir. 27910.
No, there is, because PCC are of two types. One is three factors and one is four factors. You should know the difference between them. I think one is 279 and one is 27910. You can confirm it. I don't remember exactly. Okay. What is the problem if we give this PCC? What can be the problem? It can cause it can cause acute thrombosis. Okay.
Acute thrombosis.
So it can cause acute thrombosis. So whenever we are using it, we have to be very careful. Okay. So
Yes, sir.
another fundoparanox, actually there is uh, okay. So fundoparanox is a synthetic saccharide which emulates the structure of heparin antithrombin binding site. Okay. So it indirectly inhibits factor 10A and is given by subcutaneous daily injection. It is more effective in preventing VT than low molecular weight heparin, but also at producing bleeding. The half-life is long, and the drug-free time before neuroaxial block is thus 36 hours. It has a low incidence of hit and has been used as low molecular weight heparin substitute in this condition. Let's see what was the point why they choose danaproid, not fundoparanox. Okay, so let's review here. So this is lady, 65-year-old woman. Okay, and she's post abdominal hysterectomy. So that's why they don't want to give, which can cause, it has incidence of bleeding. So that is why I think they don't choose fundoparanox. I think let's see why they choose this one. Just a second, because uh, okay, because this point they have said here, I just want to clarify one thing. Just a second. A number of people who have joined for the first time, uh, you are all welcome. And when do you say that the clinical effect of some medication is finished? What is half-life? When drug concentration decrease by 50%. Okay.
50% on initial value.
So initial value. So after how many half-lives the clinical effect will be finished?
Almost 3 to 4 half-lives.
No, 5. 50,
5.
25, 12.5, 6.25, and 3.125. So when it reaches this will be the time. So 1, 2, 3, 4, 5. Okay. So whenever we are calculating, we calculate like that. So after 5 half-life, the drug concentration will become subclinical. Okay. So that is how you should be. This is a concept which should be understanding. So Fundoparanox, it's also a medicine which can be used for HIT. The patient who has HIT. Okay. But it has more tendency for bleeding. Okay. Lapuridine is a herodin derivative made as recombinant protein in yeast whose main use in HIT. It directly inhibits thrombin. So you see the mechanism of heparin through anti-3 and factor 10A. But factor 10A is less. So indirect effect is less. Low molecular weight heparin has more of effect through factor 10A. Okay. So heparin, unfractionated heparin, antithrombin 3, low molecular weight has more through factor 10A. And what it does, it inhibits factor 10A indirectly. Okay. So it is also through factor 10A. And lapuridine, it is direct thrombin. It directly inhibits thrombin. Okay. Because these are all high yield points for your MCQ. You should make a list. I will try to find a document which we had when we were preparing for exam, but I was not able to recognize the name. If anyone recognize it, he's extraordinary. So lapuridine is direct thrombin inhibitor. Okay. And given continuous infusion. Then danaproid. Danaproid is like heparin. Danaproid is heparinase that inhibits factor 10A and can be used in patients with HIT. There is a need for close monitoring as some HIT prox reactivity does occur. It has not replaced the use of lapuridine in the management of it due to a forementioned withdrawal. What they have written, due to manufacture cessation of product in April 2012, lapuridine is no longer available in UK. Notably, this withdrawal was not due to any safety concerns. So it's not available lapuridine. So then that's why danaproid is it. Dabigatran is an orally administered direct thrombin inhibitor. So another direct thrombin inhibitor. Okay. So dabigatran, license for VT prophylaxis after it does not require monitoring, but also lacks any method to reverse the anticoagulant effect. Okay. Rivaroxaban is a direct oral. So you should know that which are given orally, which anticoagulants are given orally. So dabigatran, rivaroxaban, oral direct or inhibitor of factor 10A is becoming more common more previously for post-operative VT is now being used in atrial fibrillation and in Europe as an adjunct to aspirin and clopidogrel in acute coronary syndromes. They are giving a post PCI. The likely diagnosis in the above patient is an episode of HIT. HIT is an immune-mediated IgE response to an immunogenic component of heparin, leading to thrombocytopenia. This occurs in around 3% of patients. I have a question. So this is a clinically relevant thing. So you should just revise this point that there are two group of people, some of them, they use heparin in the like when they are preparing for arterial line, in the preparation of this normal saline, some hospitals they put it, but actually it's not recommended because even this amount can trigger hit. So you don't know which population is having hit, so you should take care about it. So actually, that's why it's not absolutely recommended to put heparin in the preparation for arterial line. But still, you will see a lot of people doing it. But I think it you should be doing it carefully. Okay, this occurs. Okay, consequence treatment with unfractured heparin and less so at a rate of 0.1 to 1% with low molecular weight preparation. Paradoxically, the risk of thrombosis is increased to 50% at this time. So alternative form of anticoagulation are needed. Platelet counts should be monitored for day 4 to 14, which is risk period for antibody formation. Although the diagnosis is not absolutely confirmed, and the question forces you to respond and treat is the safest in the safest way possible. If hit is possibility, then a heparin infusion should be provided, as should low molecular weight, as this can also precipitate the condition. In addition, the dose of low molecular weight is probably too high, given that she is no longer on anticoagulant treatment. Aspirin may or may not be indicated for this patient in terms of primary cardiovascular prophylaxis, but does not have any role in thromboprophylaxis, as I told you. Of the two hit safe options, fondaparinux and danaproid, as I was telling you. Only danaproid has no association with hit. Fondaparinux has a very low rate of giving rise to hit and sometimes used off license as a treatment. However, in this scenario, the long half-life makes fondaparinux irreversible and uncontrollable in the immediate post-operative phase. From day 2 onwards, without bleeding, fondaparinux would represent a good choice for prophylaxis with adequate monitoring of platelets. So, like the question was, in the immediate post-operative period, which is better choice? So actually, for that, you should have a very extensive knowledge of these. If this question comes to your exam, it will be a very challenging question. So you should be knowing the individual properties. So as they have mentioned that fondaparinux, one thing you identify that it has a long half-life. Okay. So if anything occur, you cannot you cannot reverse it immediately. So that is one point. And the other point is that danaproid has lowest risk of hit. So among the medications, that's how they choose the answer. But for that, you need to have a very good, I will show you here. If you go to this, it's this in blood. And then you will come here, coagulation, anticoagulants, antiplatelets, and you will find even the topic of hit. Okay. There are two articles on hip. This is tutorials. You can have a look here, and then some these are you will find here on the anticoagulants and antiplatelets. Okay. Okay. So there are a lot of information there. You see about rotom or theg you want to know, and then just a second. So about tranexamic acid, thromboprophylaxis. You can just have a look. Let's have a look on one of the article. Mm, we should we will just
So can I add
concentrate here.
something?
Yes, yes, please.
Yes, sir. So basically, as far as I remember this topic, there is a lot of time ago I read that. So hit, there are two type of hit. One is non-immunogenic and other is immunogenic. So hit
Yes,
one is basically non-immunogenic. It usually occurs with 1 to 2 days, and it is not so complicated or
yes,
harmful. But hit two is
yes,
immunogenic. That is more complicated, and that was talking in the MCQs that IgG is formed against the platelets.
yes,
So this point
yes.
was.
Very good, very good. So there are two types. You are absolutely right. Okay. So you will find here, you see about novel agents about this. So, of course, this again, I told you, this topic always initiate vomiting reflex in me. So pardon me for that. I'm just showing you another option, common medication. You see here they are written. So dabigatran is factor 2A, rivaroxaban as 10A, also 10A, 10A, and then there will be direct thrombin inhibitor, that is dabigatran, and even this danapride, as we read here. Okay, so you can extend. So learning points for this MCQ will be, if you just chalk out again that how, what is the mechanism, and then that's what we were discussing, that how we have to prepare this topic for our other project, is that you will have to combine the data, how the thrombogenesis occur. Okay, what are the risk factor for uh, increased thrombogenesis, then what are different this cell-based model, and the traditional extrinsic intrinsic pathway. Okay, and then you will go in details of various modalities, the physical modalities and the pharmacological, and then different types of anticoagulants. So that's how uh, we have to bring all the data together at one place. Okay, because this topic will come in different varieties. It's just a chance that two questions simultaneously have come here with the same. Uh, okay, so you can find almost all information about anticoagulants and thromboprophylaxis. You see, this is also chronologically. If you find any latest guidelines, that will be the best thing. But the basic thing, you see, it will help you from here. Okay. Another thing which is I did not mention, unfortunately, is vena cava filter. Radiologically, interventional radiologists, they place it. If the patient is at high risk of embolism, actually, or there is a clot, so in that cases, they place a filter, or there is DVT. So in that thing, they need to place a filter. Okay. So we will come back to this topic some point of time. Okay. So now the other question. A 21-year-old woman is undergoing a Leafort 1 transverse osteotomy to correct her maxillary retrusion. Actually, like the Leafort fracture is something else, and this one osteotomy, actually, this is a reconstructive surgery, a cosmetic surgery, a number of times. A nasal tube is used and anesthesia is maintained by propofol and remifentanil infusions. So now you can think about what are the pros and cons and problems associated with nasal intubation. Can someone tell? What are problems? So you should be knowing that whenever you are doing nasal intubation, you have to make sure the patient does not have history of DNS or any polyps or anything, or any nasal bleed, epistaxis. So you have to take the history. And then if the patient has blocked nose, so that's another thing. When you want to do it, you make sure that you put some this decongestant, and then also the lubrication. And if it is not going easily, don't push too hard. These are rules for nasal intubation. Another important point is that the ideal tube for it is the silicone tube, which is less traumatic. So these are the points which you should be knowing with reference to nasal intubation. And make sure that when you are doing the consent, tell the patient about nasal intubation. Okay, that we will be putting this surgery. We have to pass the tube through your nose, and rarely it can cause post-operative pain, bleeding and pain. So you have to inform the patient about it. So that's something, the points which you should be knowing about practically, as well as if you are handling any situation, so you should be knowing about it. Then remifentanil. What is the advantage of remifentanil? Remifentanil infusion is being used, and it has the there is a concept of context sensitive half life. Okay, so context sensitive half life is the time when, after long infusions, when we stop, after how much time the clinical effect will be finishing. So remifentanil, because it is metabolized in the blood, so it is among the medications, anesthesia medication, it has the shortest context sensitive half life. Okay. So the patient will be suddenly awake. Rather, there is a very big danger of opioid induced hyperalgesia. Okay. And actually, I have seen terrible effect of this problem. I have faced myself. So if remifentanil infusion is to be stopped, make sure you give alternative opioids or alternative analgesia well in time. Preferably, like if you want to continue the analgesia, you should give fentanyl and morphine, both of them. Why both of them? Because morphine will take at least 10 to 15 minutes for its effects. Fentanyl effect will be coming relatively quicker. Okay. So then you can easily. And another thing, if you give fentanyl, you don't know how much is the requirement. So it's always better to give both of them, so that one effect finish and the other effect will also takes his part. So opioid-induced hyperalgesia is a very dangerous thing. It can create a lot of problem with remifentanil. Okay. So what they are saying, during the down fracture, her pulse rate falls to 29 beats per minute, and her blood pressure 70 by 30. Her oxygen saturation and tidal wall CO2 and airway pressures remain unchanged. So saturation does not fall, and tidal does not fall, and airway pressures remain. So why they are telling this thing? Because if there is any anaphylaxis, then maybe heart rate will go up and airway pressures will go up, and end tidal CO2 maybe there will be some element of bronchospasm. So most probably there is some reflex which has caused bradycardia. Okay. So actually I just so this is trigeminocardiac reflex. Remifentanil, by the way, remifentanil can also cause bradycardia, but the picture will not be like this. So hemorrhage, usually if the blood hemorrhage occurs, there will be tachycardia with hypotension. Okay. And venous air embolism, their end tidal CO2 will go. Endotracheal tube damage will not present like this. So let's see what they have explained about trigeminocardiac reflex. Again, the facial-maxillary surgery, some of the procedure you should know about it. And again, because majority of people are relatively new for me in this session. So remember one thing, whenever we prepare any scenario-based question, even you see, even in this question, one is category of patient, like 21-year-old. Here there is no medical disease, but in number of conditions there will be some medical disease. And the third will be the surgery. So you have to take care of three things: the patient category, the medical disease, and the surgery. By the way, can someone tell? Just think, just a brain exercise. What are the problems you can face in young females? Yes, Sayyid Muhammad Ali Shah.
Regarding sir, remifentanil.
No. Young female. Young female can have some. Whenever you are dealing with a young female, You should be thinking about and a patient that lady can be more anxious. Okay. There is
Okay.
a condition which is called as anorexia nervosa. What is that?
Sir, this is basically psychiatric condition in which
Yes.
uh, young patient is hesitant to eat, or when they eat, they abruptly have a urge to puke.
Yes. So actually they want to lose weight. They don't want to get fat. So they initiate even vomiting. Okay. So and you can just think about it. You can think in every patient category like another, because just to make you understand, a 55-year female and 55-year male, what one difference should come to into your mind? A 55-year-old female can be
More anxious.
no with something else. Think this age group is prone for something perimenopausal.
Vasovagal. Oh, polymer.
Perimenopausal. Okay. So, that is how you make up your mind. And these are the things which should be in your mind. Okay. That this age group may be perimenopausal. So they have chances of hypertension, just goose flesh, psychological problems. So these are more prone. And up to that age, actually, the incidence of cardiovascular problem and endocrine problem is more in males. And after that, it is almost equal, or I think more in females, if I'm not wrong. Okay. So uh, that is how you have to do the brainstorming. So what they are telling now, horizontal Lefort one osteotomy is a common procedure used to correct maxillary deformities, and knowledge of the surgical technique and relevant anatomy is useful in recognizing and treating complication. Surgery involves an intraoral incision and formation of transverse maxillary osteotomy that extends into the trigomaxillary junction. The maxilla is then separated from the upper face along this osteotomy plane by a down fracture and fully mobilized to aid surgery. Bleeding is a recognized complication due to the down fracture since the bony mid face receives a rich blood supply and is in close proximity to an extensive venous plexus. The blood vessels most likely to be injured during the down fracture are the pterygoid vessels, palatine, alveolar arteries, or on rare occasions, the internal carotid. In order to visualize a source of bleeding and achieve hemostasis, completion of down fracture is often required. It is unusual for an acute hemorrhage to present with a severe bradycardia, as venous air embolism can occur during any head and neck surgery above the level of heart, okay, where open veins are exposed to the atmosphere. However, end-tidal CO2 level would be expected to fall as a result of an increase in physiological dead space and intrapulmonary shunting, which is not observed in this case. By the way, just another food for thought. What, why there is loss of end-tidal CO2 in venous air embolism? Can Ali, you explain this?
Sir, venous air embolism is basically usually usually is a complication of posterior cranial fossa or any craniotomy, or usually hysteroscopy in the gynae. So the air move from the vessels to go into the right atrium, from right to right ventricle, and from the right ventricle into the pulmonary arteries. So they usually stuck the blood, so venous return is quickly dropped. That is why there is no carbon dioxide to exhale, and tidal abruptly falls.
Then the PaCO2 will also decrease.
Yes, sir. PSO2 is also decrease. No, PSO2 will increase.
So you are caught. Actually, what happens when there is no blood going to the lungs? Okay, there is no exchange. So in the blood, PaCO2 will increase. Okay, but because there is no exchange, it's like a dead space. Okay, as there is no exchange of gases, so no CO2 going out. So that's why end-tidal CO2 will go, but in the blood, PaCO2 will be very high. Okay, because CO2 is not washed out. two embolism are acute and two embolism are subacute. Okay. Two embolism are acute and two embolism are subacute. What are the acute embolisms?
Mm. Sir, fat embolism and amniotic fluid.
If they are acute, they are subacute. Thromboembolism, if it is massive thromboembolism and air embolism, are much acute than
Okay.
amniotic fluid embolism and fat embolism because both have both obstructive and immunological theory. Okay, because
Okay.
embolism they have two theories. One is physical obstruction and one is immunological mediation. Okay. So just a revision of embolism. The nasal endotracheal tube is usually the airway of choice when correcting for maxillary retrusion, since the jaw is frequently closed and wide to ensure normal alignment of the upper and lower teeth. During the ostomy and down fracture, the nasal tube may be damaged, resulting in impaired gas exchange. Okay. And secondary hemodynamic compromise. In such a situation, the airway, which is now likely to be difficult, needs to be reestablished. This scenario is likely to unlikely in the above case, since the oxygen saturation and tidal CO2 and airway pressure remains unchanged. Okay, so they are telling that airway is not. The leaford hysterectomy can also uh, cause nerve damage and pressure effects to cranial nerve 2 to 7 due to their proximity to the surgical field. A recognized complication of maxillary down fracture is the generation of trigeminocardiac reflex. This reflex occurs as a result of pressure on cranial nerves trigeminal initiating a vagal reflex, causing a severe bradycardia, which may even progress to asystole. Cessation of the down fracture and return of the jaw to its original position can increase the heart rate, and as can administration of anticholinergic drugs. The isolated bradycardia and hypotension in relation to the down fracture in the above scenario makes this reflex the most likely cause. Okay. Actually, with the remifentanil and propofol infusion, overdose it can. But when they are saying in this scenario, what they said that if when they were doing during the down fracture, okay, her pulse rate falls to 29 beat with bradycardia and hypotension. So that is the reason. Again, that because of direct, because actually, remember one thing, there are some tips to pick the answer when you are doing it actually, because no other will cause. Uh, what is the prominent thing here? Bradycardia. Okay. Usually, hemorrhage, no bradycardia. Even in embolism, no bradycardia. Endotracheal tube damage, no bradycardia. Remifentanil infusion, yes. So actually, the tie is between these two. But if it has to occur, it can occur even before that. So they have mentioned here, especially at the occurrence of down fracture. So that's why the answer is this one. Okay. So this is just for, of course, we are right now, we are doing something else. We are exploring and we are doing mind exercise and we are increasing our knowledge. Okay. So in this almost 50 minutes session, we have touched so many points. And that is what I say as the MCQs based learning, that whenever you are read MCQ, the concept which is being told to you, where is the queen? Do you know why I'm saying this word, Ahmed? Sorry, Ali. Where is the queen? What is the concept of where is the queen?
Sir, carom board.
No, 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 no. Yes, yes, Karam also. If you remember the Munna Bhai MBBS, the old Baba, even he was looking to have the Queen Rani. Okay, so whenever you
Yeah,
are
yeah.
reading, actually, unfortunately, you are only looking where is the answer. So your answer is the Queen. But actually, when you are practicing, you should expand your knowledge. Okay, because your expansion of knowledge, what will happen, that initial days of your preparation, you will even one question will take hours, but believe me, if you study like this, after 1 month you will have so much knowledge that gradually the this exercise will become easy and easy and easy. Okay, so that is the concept of uh, how you should do the I love MCQs. The people who studied with me are witness for that thing. Even whatever exams, international exams I did after my FCPS, believe me, I did MCQs based. I used to read like this. These books, which are now available in soft copies, believe me, we used to have in. I ordered. We like together, me and my friends ordered through Amazon, and I think at that time maybe we spent around 100,000 rupees at that time, 2015, 10 years ago. So now these books are available like a freebie. Okay, but we all have these books hard copies because these were relatively newer books at that time. So, but the concept is what I'm telling you. Try to another message related to today's discussion is that venous thromboembolism or any guideline, try to find out the latest one. So, Ali, if you can search online that what is the latest guideline with reference to thromboprophylaxis, I will be obliged. I will also try to search, but
Okay,
if you
okay, sir.
search that if NICE, because do you know NICE is National Institute for Clinical Excellence. So actually, they do the guidelines for so many things. So and then another guideline which you should be knowing is AAGBI. Okay, American Society of Anesthesia guidelines and this American Society of Regional Anesthesia guidelines. So you should be knowing the guidelines. So thromboprophylaxis guidelines, you can write in Google and you will find some document. So the basic thing is that what are the like you when you I asked you, you told so many things for I asked to Wajiha, I think she has gone. Wajiha, you are here or gone? I think Wajiha has gone. She has actually Viva after 1 day. So it was nice that even if she was here, but actually there are you can classify that there are certain patient factor, anesthetic factor, and surgical factors which can lead to thromboembolism. So then it will become easier for you to remember. And it is said classify or die, classify or die. Okay, so it's always nice that you classify some things. So the learning objective for today's discussion, as I discussed with you, thrombogenesis, thromboprophylaxis, various types of anticoagulants, which anticoagulants are used if there is hit, which anticoagulants are oral, which anticoagulants acting direct thrombin inhibitor through factor 10A, through antithrombin 3. So then these are the learning points with reference to that thing, and that what are different ways for getting thromboprophylaxis, and what are the clinical interpretation, how you monitor them. And another question, last question before I finish, Ali, is there any condition in which the you give heparin but it's not effective? Do you know any condition? Like in the cardiac surgery, you give heparin, okay, and there is no rise in this ACT. So what's the problem?
Sir, there could be a thrombin deficiency.
Antithrombin 3 deficiency, not thrombin deficiency. So
Antithrombin, sorry,
antithrombin
antithrombin
3
3 deficiency.
deficiency.
Yes.
So there are patients who have absence of 83. So actually in that we give FFPs.
It could be in the nephrotic syndrome also because there is also decrease in antithrombin 3. No?
Anyways, so you have to see about it, that what are the when heparin is not effective. So though three things you should be knowing about it. What are different forms of heparin? What are the doses of heparin? How much is the duration of action of heparin? In which condition heparin will not be effective? In which condition heparin will become a dangerous thing and causing thrombocytopenia? Okay. So I think that's it for today. And I hope you got something. And inshallah, we will continue our. So what severe bradycardia hypertension are recognized complication. However, the temporal relationship between the down fracture and the bradycardia in the above case make the trigeminal reflex more likely. Okay. So if you see you can find if you want to, for example, because CEA, CCP articles are arranged by me in the articles. So you will go, this is CEA, CCP, and BJ education are the same. It is the previous name of BJ education, continued education in anesthesia, critical care, and pain. Okay. And BJ education is the new name of this thing. Another thing I just, because some of the juniors are here, just a second. Yes. You know what is difference between a research article and review article? Yes. Yes. Anyone? Ali?
Sir, basically, research article is specifically one type of article on that research has been done. Review is basically a broad spectrum. To two to three types of researches are combined, like meta-analysis, systemic analysis, and it is built in form of a systemic way.
Your synopsis dissertation is research article or review article?
Research, sir.
Research. Okay. So actually, these articles are review articles. Okay. The anesthesia tutorial of the week and these BJ education, they are review articles.
Review.
So you, because from review article, books are written. A lot of review articles, they write the books. So they get they take some information from the research articles as well, but mainly the review articles are the source of books. So that's why, because in today's life, we are developed and we have so much access to the information. So there is no indication for you guys to have a look on the sorry, to do it from the books only. Because these review articles, they are written in such a beautiful way that they give you a very compact view. You can open it like a gallery, and it's like a, and you don't need to read each and every line of the article. You just have to understand what is the topic, and then you can scroll through it and you can make your own list. Okay. So this I will suggest you, and I have arranged like a separate link for year-wise articles in the main group description. You will find it, and here I have arranged anesthesia tutorial of the week, BJ education updates. So all are arranged. Like for example, is anesthesia tutorial of the week. It was started in 2005, and you see up to 2025, all articles are arranged. Okay, so that is how you can use them. You can go topic wise. You can. So that's how I will
क्या
suggest you
कहाँ
to.
हो मेरा फोन ले ले ये ले
Okay, so thank you very much, all of you, for your time, and inshallah we will meet again. Okay, bye bye.